Right now, inside thousands of hospitals, CT scanners are spinning continuously, capturing cross-sectional data of the human body at a massive scale. This high-throughput reality creates a stark discrepancy. Every year, 19 million routine chest CTs are performed, compared to only 600,000 dedicated cardiac scans. These 19 million scans are ordered for siloed reasons, evaluating lung cancer, shortness of breath, or pre-ablation anatomy. The patients undergoing these pulmonary and surgical evaluations share a distinct demographic overlap. The vast majority already carry recognized risk factors for atherosclerotic cardiovascular disease. This overlap opens the door to opportunistic screening. Instead of ordering a new test, we can extract secondary, life-saving diagnostic data from the images that have already been captured for entirely different primary reasons. Extracting this latent data requires zero additional radiation exposure to the patient, and it incurs zero additional scanning costs to the healthcare system. The specific biological marker currently sitting unread in millions of these chest CTs is coronary artery calcium. Leaving this data on the table represents a systemic failure in preventive cardiology. By ignoring the imaging we already have, we are missing a 30-to-1 diagnostic arbitrage opportunity to identify patients at risk of heart attacks. The primary target here is atherosclerotic intimal calcification. This is distinct from the medial artery calcification that occasionally shows up in patients with chronic kidney disease or advanced age. Atherosclerotic calcification begins when lipid-rich and inflammatory materials breach the arterial wall, coalescing into jagged microcalcifications deep within the intimal layers of the coronary arteries. This diagram illustrates the cardiovascular risk continuum. Microcalcifications accumulate into larger lesions, tracking with actual plaque burden expansion. This clinical danger scales with calcium density. A score over 300 carries a risk equivalent to asymptomatic obstructive coronary artery disease. Pushing to the extreme upper limit, a score greater than 1,000 places a patient in a risk category identical to someone who already has established stable cardiovascular disease. Conversely, a score of exactly 0 operates as a clinical warranty period. It is one of the strongest negative risk markers available in preventive medicine. Despite this severe prognostic value, incidental coronary calcium is systematically ignored. It is routinely underreported on non-cardiac scans. This blind spot is driven by radiologist inertia, a general lack of clinical awareness, and historically the absence of standardized quantitative metrics for scans outside of dedicated cardiac workflows. The biological validity of measuring calcium is moot if the clinical diagnostic pipeline lacks a standardized way to extract that data and report it back to the primary care physician. The current gold standard for quantifying this plaque is an ECG-dated, non-contrast cardiac CT. This dedicated scan uses the Agatston scoring method, which calculates total calcium by multiplying the area of a lesion by its peak density. Opportunistic, non-gated scans face a strict physics problem. Routine chest CTs use thicker image slices and capture the heart while it is rapidly beating, without synchronizing to the cardiac cycle. These physics alter the data. Thicker slices cause partial volume artifacts, where small calcium deposits blend into surrounding tissue, modestly underestimating the true calcium score. Conversely, high heart rates create motion artifacts that can overestimate the score. This list details the technical challenges of interpreting non-gated chest CTs. A major secondary pitfall is the faulty inclusion of non-coronary structures, where radiologists must differentiate true coronary calcium from nearby extracoronary findings. Here we see specific anatomical challenges. The bright white deposits on the mitral annulus and the aortic valve can easily mimic true coronary artery calcium on a lower resolution scan. Faced with these physical and anatomical hurdles, many radiologists simply opt out. They choose not to report incidental cardiovascular findings at all. To resolve this friction, the Society of Cardiovascular Computed Tomography and the Society of Thoracic Radiology created a validated translation layer. Solving the opportunistic screening problem required abandoning the pursuit of perfect quantitative precision. Instead, the focus shifted to actionable, qualitative categorization. The result is the Coronary Artery Calcium Data and Reporting System, or CAC-DRS. It serves as a critical translation lexicon for radiologists evaluating non-gated scans. This system relies on a visual scale. Radiologists categorize observed calcium subjectively, from V0 for absent up to V3 for severe. Next, they track spatial distribution, indicating the number of involved vessels, grading N1 to N4 across the 4 main coronary arteries. This spatial tracking is crucial because a wider dispersion of calcium across multiple arteries inherently correlates with a higher clinical risk profile. This matrix demonstrates how visual inputs map directly onto a standardized reporting system, bridging subjective estimates with quantitative Agatston scores. The translation is direct. For example, a visual V3 score on a routine lung scan reliably corresponds to an Agatston score of 300 or greater. This simple alphanumeric code empowers radiologists to bypass complex physics arguments and immediately communicate the severity of a patient's risk. CAC-DRS removes the excuse of imprecise data. It creates a direct, standardized bridge between a routine lung cancer scan and a targeted cardiology consult. Even with a standardized lexicon, a workflow bottleneck remains. Human radiologist reporting is highly inconsistent, relying entirely on individual initiative and time availability. Deep learning algorithms provide a scalable method for automated detection. Applied directly to the pipeline, the software identifies and quantifies isolated calcium deposits in real time. Current deep learning models achieve greater than 90% sensitivity and specificity for detecting coronary calcium on non-gated chest CTs when compared against dedicated ECG-gated cardiac scans. Unlike the ordinal ranges of human visual scoring, deep learning extracts continuous quantitative variables, generating specific numerical outputs like 1, 99, or 200. This hazard ratio chart plots the prognostic validity of deep learning quantification on routine non-cardiac scans. The data confirms that an automated score of 100 or greater yields a 69% increased risk of death, myocardial infarction, stroke, or revascularization. Integrating AI into these workflows enables every routine chest CT to function as a predictive cardiovascular tool, identifying at-risk patients without requiring additional human labor. Detecting calcium is only half the equation. The raw diagnostic data is clinically useless if it does not alter prescribing behavior at the physician level. This flowchart outlines the age-stratified workflow logic necessary to govern how physicians should react to incidental findings. The protocol is aggressive. The detection of any incidental calcium, a visual score of V1 or higher, warrants the early initiation of preventive therapy. For the middle-aged cohort, between 40 and 74, the entire scoring range is relevant. The specific severity dictates routine risk stratification and determines the appropriate intensity of statin therapy. For patients 75 and older, the protocol introduces a nuanced option. If the incidental scan reveals a calcium score of 0, physicians can consider safe deprescription of existing medications or apply more leniency in risk factor goals. When scores exceed 300, the response scales beyond basic statins. Severe incidental calcium may trigger the allocation of advanced therapies, like PCSK9 inhibitors, low-dose aspirin, or GLP-1 agonists for weight loss. Raw diagnostic data only becomes actionable when it is filtered through precise, demographic-specific clinical guidelines. The final hurdle is a systems engineering problem, bridging the gap from radiologic detection to the point of care, ensuring the primary care physician actually writes the prescription. This is a best practice advisory, a behavioral nudge built directly into the electronic medical record. When elevated calcium is detected, the EMR prompts the physician with targeted, dosage-specific statin recommendations. The advisory removes workflow friction entirely. Based on the automated read, the physician can order the appropriate statin and a follow-up lipid panel with a single click. This flowchart details the Notify-1 trial, which tested this exact systems engineering approach in a real-world clinical setting by randomizing patients into a notification arm versus a delayed notification control arm. The outcomes are definitive. Simply notifying clinicians of a deep learning detected calcium score from a prior chest scan shifted statin prescription rates from 12% in the control group to an overwhelming 78% in the notification arm. A final challenge remains: ensuring equitable access. Hospitals distant from major academic medical centers may experience longer adoption times for this AI software, risking a socioeconomic divide in preventative care. Opportunistic CAC screening is now a proven clinical workflow. By combining a standardized visual lexicon, deep learning algorithms, and precise EMR integration, healthcare systems can deploy a zero-cost pipeline to systematically identify and treat subclinical atherosclerosis.